Hello, I am Dr. Theophany Mella from the Cardiac Arrhythmia Service at Mass General Hospital, and I will talk today on arrhythmias in women. As an introduction, I would like to share with you information on sex differences in cellular electrophysiology and ECG, the channelopathies, supraventricular tachycardias, atrial fibrillation, and a few words on the thromboembolic risk and anticoagulation, sudden cardiac death, device therapy with the use of ICDs and CRT devices, and finally, a part of my talk will be on arrhythmias in pregnancy. In terms of the sex differences in cellular electrophysiology, the information in this field has been evolving over the years with many observational and basic research studies, which are usually small in the number of patients included. But some consistent findings include the fact that female and male ventricular myocytes appear to differ with respect to size and kinetics of calcium currents. At slow pacing rates, action potential duration of female myocytes is longer than that of male cells. And some plausible findings include that sex hormones influence calcium currents and potassium currents differ in female and male cardiomyocytes. The manifestation of the differences in cellular electrophysiology is predicted in the actual differences in the electrophysiological variables that we see in the various sites inside the heart. Starting from the sinus node, the cycle length in females is shorter than that of males, so females usually have a higher base heart rate. Moving to the atrioventricular node, the effective refractory period of the AV node in females is shorter, and that may account for a faster conduction between the atria and the ventricles. And the same holds true for the His bundle area, where the HV interval is shorter, so therefore faster conduction from the atria to the ventricles. Looking at the refractory period of the atrial tissue, that is shorter in female atria, whereas the refractory period in the ventricular tissue is longer for female ventricles, and therefore making women maybe less prone to ventricular tachyarrhythmias and more prone to atrial tachyarrhythmias. And the QTC, which we will talk more about further down, appears to be longer in general in females. The main EKG differences between males and females include the QT duration. And as we can see in this diagram from the Framingham study, the QTC progresses, elongates over the years according to the age of the patient in a more linear way in women, and after it gets shorter during after puberty years for men, subsequently also for men. In terms of some established findings regarding the sex differences in EKG, at slow baseline heart rates, premenopausal adult women have longer QTC intervals than men of corresponding ages. And some consistent findings is that the QTC difference between premenopausal women and men of similar age diminishes with increasing heart rate. Women have marginally shorter QRS complex than men. Women have steeper individual QT over RR interval profiles, therefore QTC, and women have a larger spatial differences between QRS and T-wave loop orientation. In terms of what is normal for women, a QTC less than 460 milliseconds is considered a normal QT interval. For men is slightly shorter at 450 milliseconds. The EKG and electrophysiological changes that we see, the differences that we see between the two sexes are definitely influenced by hormonal changes. And as we see on the diagram here that follows the menstrual cycle of a woman, during the follicular phase when the estrogen is elevated, there could be increased function of the IK channels, so decreased function of the IK channels, increase of the action potential duration, increase of the QTC, and therefore some females can be more prone to torsade de pointes during that period and less prone to supraventricular tachycardia, also due to maybe some autonomic changes when the heart rate decreases and there is a vagal predominance. Whereas during the luteal phase, when progesterone is higher, there could be increased function of the IK channels, decreased duration of the action potential, and decreased length of the QTC. Therefore, women may be less prone to torsade de pointes and more prone to supraventricular tachycardia, also due to some autonomic changes like the heart rate increase and the sympathetic predominance. Moving to the topic of channelopathies, I would like to spend some time talking about the long QT syndrome as it is the one that we most frequently see, and as is the one that there could be some difference between genders. Long QT syndrome is present when a patient has a QTC longer than 480 milliseconds or 460 milliseconds along with unexplained syncope, and that applies to both women and men. The three more frequent types of long QT syndrome: LQT1, 2, and 3. LQT1 is caused by a mutation in the KCNQ1 gene, which regulates the slow IK channel. The difference between genders is that boys with long QT1 are at higher risk for arrhythmic events, higher than girls, whereas after the age of 16, that relationship changes and women remain at a higher risk for arrhythmic events throughout her life compared to men. Long QT2 is caused by a mutation in the KCNH2 gene, which regulates the IKR channel. And long QT2 is placing women at the highest risk for arrhythmic events at all ages. And finally, LQT3, caused by a mutation in the SCN5A gene, affects men and women in an equal way in terms of future arrhythmic events. When we try to risk stratify patients, we have in mind this diagram. It was first published by Silvia Priori and colleagues in the early 2000s, and it remains true in terms of risk stratification of patients. So at the highest risk, we have patients with prolonged QT more than 500 milliseconds, and LQT1, LQT2, or males with LQT3. I included that really LQT2 is the most dangerous for female patients when their QTC is longer than 500 milliseconds. Intermediate risk patients are those with QTC that is not as long, less than 500 milliseconds, and it could be females with LQT2, LQT3, and males with LQT3, and females with LQT3 and more than 500 milliseconds, and low risk are patients with shorter QT interval and males with LQT2 and both genders with LQT1. Moving on to different types of arrhythmias, I would like to spend a few seconds on supraventricular ectopy, which is probably one of the most frequent arrhythmias that we encounter. Supraventricular ectopy appears to be equally prevalent in both sexes. In a healthy population, in the Copenhagen heart study of people with ages between 55 and 75 years of age, they found that a significant amount of patients who were even potentially asymptomatic had an excessive ectopic activity of more than 30 beats per hour, or short runs of 20 beats or more. And that was true for 35% of the women patients and 42% of men patients, so a significant percentage. For those patients with excessive amount of supraventricular ectopy, 60% of them had an increased risk for death or stroke, and their risk to develop atrial fibrillation during the follow-up of 6 years was 27 times higher than people with less supraventricular ectopy. So a condition that we although consider benign, it is highly recommended to be treated with beta blockers or ACE inhibitors, ARBs, that could change the atrial remodeling that leads to these conditions. Supraventricular tachycardia, so sustained tachycardia, sustained supraventricular ectopy. A few interesting epidemiological comments. Women are 2 to 3 at a higher risk to develop AV nodal reentrant tachycardia, probably the most common supraventricular tachycardia, whereas orthodromic reentrant tachycardia, the one that is associated with the presence of an accessory pathway, is twice as common in men than women. As we have already alluded, and we'll talk a little bit more in the next slides, SVT is more common during the luteal phase of the menstrual cycle for women. SVT affects the quality of life for women much more than in men. In general, women appear to be more symptomatic with palpitations or the other characteristic symptoms of tachycardias, both in supraventricular tachycardias, but atrial fibrillation as well. Women are referred for SVT catheter ablation later than men. Catheter ablation for SVT, however, is as successful and safe in women as in men. I am including here a slide on the age distribution on the most common types of supraventricular tachycardia. And in gray, we will see the distribution of AV nodal reentrant tachycardia, the most common type of arrhythmia, and we will see that it really peaks around mid-age and older ages, whereas AVRT, the one associated with the presence of accessory pathways, is more common at younger age and much less frequent at older ages. Atrial tachycardia has kind of a regular distribution across life, small percentage of tachycardias, and equal distribution between men and women. So are hormones responsible for the manifestation of supraventricular tachycardia? So not so much as a cause, but as a trigger. A lot of small studies. This was an early and interesting one. Women with supraventricular, known supraventricular tachycardia wore halters throughout their menstrual cycle. and there was a significant accumulation of events around the time of the luteal phase, as we discussed earlier, when the progesterone level is higher and women more prone to arrhythmias. Moving on to atrial fibrillation, a disease that affects worldwide 12.6 million of women and 21 almost million men, a significant healthcare concern. As we discussed before, women, again, much more symptomatic than men, with various symptoms, including palpitations, syncope, dyspnea on exertion, exercise intolerance, lightheadedness, dyspnea at rest, fatigue, and chest discomfort. Women with atrial fibrillation are in general older when they present, have a higher prevalence of hypertension, valvular heart disease, and HFpEF, and a lower prevalence of coronary heart disease compared with men. Women with atrial fibrillation have more severe symptoms than men. Women are equally likely to receive antiarrhythmic drugs as men. Women are less likely to undergo an electrical cardioversion and PVI ablation than men. Women are more likely to undergo AV nodal ablation for atrial fibrillation than men. And women treated with rhythm control therapy have a significantly higher rate of life-threatening adverse events compared with men. And for that, I include a trend, a figure from the RACE trial, which was a trial that compared the effectiveness of rhythm control versus rate control, rhythm control with antiarrhythmics and cardioversion, and showed that the event-free survival for women was significantly higher when they underwent rate control than rhythm control. A few words on anticoagulation in atrial fibrillation. The consensus recommendations as reported by the European Society recommendations and published in 2018, where we see a green heart is things that we should be doing. When we see a red heart is things that we should avoid, and yellow heart is when the evidence, the consensus is there, but the evidence is not very strong. So in atrial fibrillation patients, female sex is associated with an age-dependent moderate risk of stroke and should be regarded as a stroke risk modifier relevant in the presence of other CHA2DS2-VASc risk score factors rather than an independent stroke risk factor. Therefore, for patients younger than 65 with a CHA2DS2-VASc score of 1 due to female sex, the risk for a stroke is really very low, less than 1% per year. And these women do not need antithrombotic therapy. Females with atrial fibrillation and one additional stroke risk factor, the ones that we know from the CHA2DS2-VASc system, should be considered for oral anticoagulation. NOACs are recommended in preference to vitamin K antagonists in both females and males with atrial fibrillation. Aspirin, however, should not be used for stroke prevention in females and males alike, since aspirin is essentially ineffective and associated to similar risk for bleeding compared with NOACs or vitamin K antagonists. In terms of the recommendations of AF management in women, we have two ways in addition to rate control, as we discussed earlier. It's the antiarrhythmic medications in the ablation. We should remember, however, that when women are treated with class 1A or 3 antiarrhythmic medications, we should be aware of the risk and symptoms associated with torsade de pointe, which is especially true for women that have longer QTC even at baseline. Women treated with antiarrhythmic drugs should therefore be periodically evaluated to confirm their eligibility for antiarrhythmic drug treatment, and women with heart failure or pathological left ventricular hypertrophy should be offered amiodarone. Other antiarrhythmic medications should be avoided. In terms of the ablation, women with atrial fibrillation are referred for catheter ablation later than men, which may reflect that AF occurs later in life in women. Women presenting with atrial fibrillation suffer worse symptoms than men. Women tend to have a less favorable result by PVI, and women suffer significantly more procedural complications from AF ablation, including perforation and tamponade. Moving on now to sudden cardiac death, a huge public health issue around the world. In the United States, more than 1/3 of sudden cardiac death cases, or approximately 150,000 events annually, occur in women. We can see in these two pies that there is a different etiology for sudden cardiac death in women versus in men. In men, a significant amount of sudden cardiac death is a result of coronary artery disease, whereas in women, that is a smaller percentage, 45%, with significant portions of women suffering from non-ischemic cardiomyopathy, valvular heart disease, various genetic causes, as well as a significant amount of women patients with no actual identifiable reasons for sudden cardiac death. The use of implantable defibrillators in women is a long topic that could take us many days of conference to analyze, but in summary, women have been underrepresented in all randomized controlled trials of ICD therapy and represented really only 10 to 32% of patients enrolled in those trials. And I have listed the most important ones, the ones that on which we are basing all our current recommendations for sudden cardiac death prevention and use of ICDs. None of these trials were powered to determine a sex-specific outcome, though many reported the interaction by sex in the subgroup analysis. Of those who received an ICD, women were more likely to have more complications, both at 45 days and also a year later, although the overall mortality rates were not different. So the consensus recommendations: women who meet guideline directed indications for ICD therapy should be getting an ICD therapy. Observational sex-specific differences in the benefits of ICD therapies are not currently supported by clinical trial results. Consensus is present to the fact that women may have a lower all-cause mortality benefit from primary prevention ICD therapy. But observational data on sex-specific differences in the benefits of ICD therapy should not be considered for the risk stratification of patients who may be eligible for primary prevention ICD therapy. In terms of cardiac resynchronization therapy, although it treats heart failure and not arrhythmias in women, but it commonly is associated with implantable cardioverter defibrillators, the one very strong point we should make is that women benefit from CRT. And they should be offered CRT. The Made It CRT trial was the one that first depicted this significant benefit that patients, female patients receive when they are provided with CRT treatment, and therefore there are strong recommendations about the eligibility of women with left bundle branch block and a QRS longer than 150 milliseconds and an ejection fraction of less than 35%, despite optimal medical therapy, that should be referred for CRT therapy. There is consensus that women with left bundle and a QRS higher than 130 milliseconds and EF less than 35% likely benefit from CRT, and they should be referred for CRT therapy. I would like to devote the second part of my talk to arrhythmias in pregnancy, as we are frequently called to take care of these otherwise young and healthy women who may still suffer from arrhythmias, usually supraventricular or ventricular ectopic activity. Women with new onset or recurrent SVT are probably the ones that we see more frequently. Rarely we see women with structural heart disease or devices, pacemakers or ICDs. But as women with congenital heart disease reach adulthood more and more frequently these days, they are expected to become mothers, and they need extra attention when they have arrhythmias. The reason for which arrhythmias may be more frequent during the time of pregnancy than when women are not pregnant has to do with the fact that the cardiovascular system undergoes significant changes in adaptation to pregnancy, and those changes include increased heart rate and cardiac output, reduced systemic resistance, increased plasma catecholamine concentrations and adrenergic receptor sensitivity, atrial stretch, and increased end-diastolic volumes due to the intravascular volume expansion, and of course, hormonal and emotional changes. The SVT during pregnancies, and here is an example of a patient of mine. PACs are very frequently observed in pregnancy, up to 50% of symptomatic and asymptomatic women, with symptomatic exacerbation of SVT in up to 20% of pregnant women. Similarly, ventricular ectopic beats and non-sustained ventricular arrhythmia are encountered in more than 50% of pregnant women, those could be, the majority of whom could be symptomatic, while sustained ventricular tachycardia is much less common in about 2 to 3 women per 1,000 pregnant women. A fair number of benign arrhythmias, in addition to the supraventricular ectopy, could be the sinus tachycardia, which is very common, especially during the 3rd trimester, as the heart rate increases overall by 25%, and as there is an associated widened pulse pressure in pregnant women, that can create a sense of palpitations, and women can be absolutely reassured about the benign nature of this. Bradycardia is quite rare. Congenital heart block is rare and does not usually pose problems during the pregnancy. There is conflicting advice about whether to advise temporary pacing for delivery in patients with congenital heart block. Spinal anesthesia for C-section may add to the risk for more advanced bradycardia, and there more serious consideration should be given. The management of arrhythmias during pregnancy includes some axioms like try to avoid all drugs for the first 8 weeks. During the 2nd and the 3rd trimester, the effect of drugs to the fetal growth as well as the overall development and proarrhythmia is significant. Pregnancy affects drug absorption, distribution, and excretion, and we should keep that in mind as we prescribe medications. And we need to separate true drug embryo toxicity from the ability of a drug to cross the placenta and affect the embryo. For that, we always ask for the additional recommendations by our neonatologists and also by our OBGYN colleagues. The pharmacokinetics in pregnancy are altered due to decreased absorption of oral medications, due to the progesterone decreasing intestinal motility, increasing gastric and intestinal emptying, and altering the gastric pH. Due to the 50% increase in plasma volume, a higher loading dose may be required. The proportion of unbound drugs increases, those lower drug levels may be associated with therapeutic efficacy. Increase in the renal excretion of drugs, increase in the hepatic metabolism of drugs, all those are considerations as we prescribe drugs during pregnancy. A note on breastfeeding women that unbound and ionized drugs that are highly lipid soluble achieve the highest concentration in the breast milk, and there are recommendations from the American Academy of Pediatrics and the Thompson lactation rating that could help decide on appropriate medications during lactation. A very important chart, something to remember as we take care and we prescribe medications for pregnant women, for supraventricular tachycardias, but also for other arrhythmias. This is based on earlier guidelines by the ACC, AHA, ESC, but we will talk about the more recent updates. So maneuvers that are absolutely acceptable and safe for pregnancy, during pregnancy, when a patient presents with sustained arrhythmia in the emergency room. Vagal maneuvers, Valsalva maneuvers, absolutely safe. Adenosine injection, absolutely safe. Cardioversion, if the patient is hemodynamically unstable, is known to be safe. Subsequently, intravenous medications, intravenous beta blockers, intravenous verapamil, metoprolol, and propranolol are the ones that have been mainly studied. In terms of chronic therapy for arrhythmias during the time of pregnancy, digoxin is known to be safe, metoprolol as well as propranolol, the most frequently used medications. When we need stronger antiarrhythmics, sotalol and flecainide are well tested. Less recommended are anyway antiarrhythmics that it's hardly they're hardly around these days, procainamide and quinidine. Propafenone and verapamil can be considered. Catheter ablation has been found to be safe during pregnancy, especially when we make an effort for the absolute minimum amount of radiation exposure during pregnancy. In most recent years, completely fluoroless ablation has been achieved, and that would be the case recommended for a pregnant patient. Finally, atenolol and amiodarone are essentially contraindicated during pregnancy, and amiodarone should be only reserved for life-threatening arrhythmias. After the update, the most recent update of recommendations during pregnancy, intravenous procainamide can only be given for very serious maternal and fetal arrhythmias, and it's a class 2B indication, and chronic management, as we discussed, catheter ablation and oral amiodarone. The side effects of medications during pregnancy for beta blockers, the most commonly used ones, include bradycardia, hypoglycemia, premature labor, metabolic abnormalities. Atenolol during the first trimester could cause growth retardation and preterm delivery. Drugs that should be avoided, again, amiodarone, phenytoin, dronedarone. Quinidine can cause a rare fetal thrombocytopenia and eighth nerve palsy, and amiodarone, again, restricted only for life-threatening arrhythmias. Cardioversion, as we discussed, it's safe. Short duration of anesthesia is what makes it safe. Generous periods of fasting is recommended. After the first trimester, intubation may be considered to decrease the risk for aspiration, and we perform it in an upright position or a left lateral position for that reason. The shock is synchronized to the mother's QRS, and induction of fetal VF is extremely rare, but that's why the fetus needs to be monitored during and after the procedure. The anticoagulation during pregnancy, warfarin during the first trimester has been associated with increased fetal loss and an embryopathy, and that's why it's contraindicated. It can be resumed in weeks 13 to 28, and it is safe during lactation. Weight-based, low molecular weight heparin, often with an anti-factor 10A monitoring, is recommended. Unfractionated heparin is safe during pregnancy, but long-term use is associated with osteoporosis and practically difficult. Aspirin is safe during the second and third trimester. Direct thrombin inhibitors do cross the placenta and should only be used in patients with heparin-induced thrombocytopenia, and there is no significant experience with NOACs up to this date. A few words on cardiac arrest, which is a very rare event during pregnancy, 1 in 30,000 deliveries, often in women with pre-existing heart condition. Coronary or aortic dissection, pulmonary or amniotic fluid embolus can be some causes. After the age of fetal viability, an emergency section should be considered. Later in pregnancy, the woman should be tipped on her left side. Cooling is not contraindicated. Continuous fetal monitoring should be performed in that case. A few words on long QT in pregnancy. An automatic external defibrillator or wearable defibrillator may be considered in high-risk women with a QTc over 500 milliseconds postpartum when an ICD is not otherwise indicated. Women with long QTc have an increased risk during the 9-month postpartum period, in particular women with long QT genotype. I could not stress this enough. Therefore, beta blocker therapy should not be interrupted for women with long QT just before, during delivery, and in the postpartum period. And I would like to mention one recent publication when we counsel women with long QT syndrome who want to become pregnant. There is, unfortunately, an increased 2 times increased risk for miscarriage and 8 times increased risk for stillbirth when the mother has long QT syndrome. And that incidence is much higher when the mother has long QT versus the father having long QT. So just some recent information that may be very important for our women with long QT syndrome. One benign condition, the supine hypotensive syndrome, a form of neurally mediated syncope unique to pregnancy. In supine position, the uterus compresses both the IVC and the aorta, and therefore there could be a reflex-mediated response to reduced filling of the right ventricle, leading to vasodilation and bradycardia. The treatment of this condition is, of course, avoiding the supine position, but also adequate hydration, elastic stockings, and salt intake. A few women have pacemakers and defibrillators when they become pregnant, and these devices do not pose any risk to the pregnancy or the pregnant woman. Good outcomes, even when the mothers receive a shock during pregnancy. There's rare need for urgent device implantation during pregnancy, and that should be then done preferably after the first trimester and with minimal amount of radiation. EP procedures should be done electively before or after pregnancy, but we also discussed about fluoroless ablation during pregnancy. There's numerous reports of safe EP procedures in the literature. And finally, a word on the external wearable defibrillator that can be a life-saving intervention for a pregnant woman that does not want to have an ICD implant during that time. In summary, the safest place for the fetus is in a hemodynamically stable mother. All drugs with a long track record used wisely are a better choice than new drugs with which there is relatively little experience. The treatment of arrhythmias in pregnant women and in their fetuses should be guided by knowledge of the hemodynamic, physiologic, and pharmacokinetic change during pregnancy. I would like to thank you very much for your attention. Have a good rest of the conference.